Good afternoon. My name is Dr. Steve Allison. I'm CEO, Managing Partner, and Occupational Health Physical Therapist at Functional Capacity Experts in Bossier City, Louisiana. I'd like to welcome you to this presentation, FCE Best Practices and Evidence-Based Model. So just throwing this disclaimer in here that the information contained in this presentation, including PowerPoint slides and handouts, are not considered the sole source of information that I use when providing professional services or rendering expert opinions about residual functional capacity. So the purpose of the presentation is to describe my background as a subject matter expert in FCEs, as well as to demonstrate some evidence-based best practices for designing, administering, interpreting, and reporting the results from an FCE, assessing an injured worker's ability to safely return to work. So a little professional background about myself. I graduated from LSU Med Center in 1993 with a bachelor's degree in physical therapy, went back, obtained a Master of Health Science in Physical Therapy from LSU Med Center in 1998, and then went on and obtained a doctorate in physical therapy from the University of St. Augustine. Been licensed since 1993, so you do the math. Been involved in several key publications, mostly FCEs, but some others regarding job analysis, post-op employment testing, and work rehabilitation. Currently serving as the Vice President of the OSIG in my second term, and I'm a board member for the Rehab Case Management Transition Services for the International Association of Rehab Professionals, IARP. Serve as on the Medical Advisory Council for the Louisiana Office of Work Comp, assisting with providing advice and recommendations regarding the medical treatment guidelines for work comp patients. Also, I've served as an expert witness in federal, state work comp courts in Louisiana and in Colorado. I've testified all total in about 110 cases in my career, and 15 of those cases were actual testimony in court. So in 2010, I set fear aside and took a leap of faith to open a private practice specializing in occupational health and specific focus on FCEs. Our practice is located in the northwest corner of Louisiana, so we border East Texas and South Arkansas. 100% of the services that we provide are related to occupational health, which besides FCEs includes impairment ratings, DOT physical exams, post-op implement testing, fitness for duty testing, drug screens, breath alcohol testing, functional job analysis, functional test validation, and then expert witness and disability consulting. Something else we do, which we're going out next week, is a ergonomic assessment, office ergonomic assessment. A lady that works from home as an accountant, she's been having some neck and upper extremity issues. So it's been a while since I've done an ergonomic assessment, and looking forward to that. So as far as the slides, I just want to mention here that I have a full bibliography at the very end of the presentation, but I've also briefly cited the sources on relevant slides for ease of reference. In 2015, the Louisiana Physical Therapy Board cleared the path for PTs to perform DOT physical exams by issuing a clarifying letter to the Federal Motor Carrier Safety Administration that performing DOT physicals was within the scope of practice for PT's license to practice in Louisiana. In 2016, direct access in Louisiana became a reality with a few restrictions. And one of our next strategic initiatives in Louisiana is to achieve entry point practitioner under the work comp system. Under the work comp system in Louisiana, injured workers have the right to choose one treating physician per specialty. So they may have one orthopedic shoulder doctor and one orthopedic knee doctor if they're injured their shoulder and their knee in the same incident. However, the work comp carrier has the choice of PT provider, and in most cases, the FCE provider, unless the treating physician specifically requests that an FCE be done by a specific provider as part of their treatment plan. Now, some of this has been muddied in the water in courts and even in the Louisiana Supreme Court. So I just kind of give you an overview of the FCE process that I use in this case, and I use typically day to day. It's a 2-day FCE for all workers' comp and personal injury cases. So the patient or client is seen in the clinic 3 to 4 hours on 2 consecutive days. So the first day consists of, we've typically already done, we've done some degree of medical records review before seeing the individual, so we know a little bit about, okay, they've had, back surgery, and this is what was done, or they've had this neck surgery, or just so we know what's going on. But so we do the medical records review. The medical records will be summarized in the report, an intake interview, the physical examination and active movement screen, some content valid functional testing, and then patient reported outcome measures as part of the comprehensive pain assessment. Then the second day, when the patient comes back in, we'll do an update on symptoms, a focused physical examination of the injured body area, do some expanded content valid functional testing, some more patient reported outcome measures, and then an exit survey, which I'll show you at the very end and discuss the reasons I do this. So in this case study, we've got a 63-year-old male. His job is a construction superintendent, and his work injury was March of 2021. So ended up, the right shoulder MRI showed a full thickness rotator cuff tear with retraction. He underwent 2 unsuccessful arthroscopic rotator cuff repairs. The first was in June of 2021. And then there was an interesting turn of events that took place in December of 2021. So 6 months later, he's going back in. They're going to do a repeat arthroscopy of the right shoulder and see if they can do a repair of the re-tear that he had. And so this was botched when the anesthesiologist actually put the nerve block directly into the bloodstream in his neck, caused him to go into cardiac arrest, and he remained in a coma for 4 weeks. And at that point, he, after coming out of the coma, he underwent dialysis treatment for renal failure that was caused by the incident. He also had a sacral bed sore that resulted in treatment with a wound vac for about a month and a half. So, pretty complicated deal. This ends up being a separate medical malpractice claim against the anesthesiologist, in addition to a work comp claim. And so that was December 2021. In June of 2022, he undergoes that second failed arthroscopic rotator cuff repair. And at this point, the injured worker is like, I need to get another opinion on this. So he finds another orthopedic surgeon, and the new orthopedic surgeon basically orders an MRI, shows that he's got a full thickness rotator cuff tear. The repairs have been torn off as well. He's got retraction and as well as a labral tear. So the new orthopedic surgeon recommends a total shoulder arthroplasty, and that was done in February of 2023. And after that, he underwent 9 months of PT, post-op PT, and then in November of 2023, guess what? The orthopedic surgeon releases him to full duty, return to work. No type of functional testing. The injured worker, he's kind of one of the bosses out there, so he's just self-imposes light duty on himself. But he does have an attorney representing on this work comp case, and it is a case that's not in Louisiana. It's from outside of Louisiana. And his attorney said, look, your employer could come in at some point and ask you why you're not doing all the duties that are required for you in this job. I think you need to have an FCE to document what you can and can't do, what your limitations are, instead of having this full duty release. So that's what spurred the orthopedic surgeon to then 3.5 years after the work accident, and a year and a half after the total shoulder arthroplasty to be seen for an FCE. So intake interview, he's got constant right shoulder pain. Pain levels are appropriate, 2 to 4 out of 10. He's got some right shoulder weakness and stiffness complaints. He also reports constant sacral pain. And again, those pain levels are 1 to 2 out of 10. These pain level ranges I always obtain in a 30-day pain range. So what is it now? What's the best and worst it's been over the last 30 days for you? and kind of use that as a guideline when we see them back on the second day to see, are the pain levels that we're seeing them on the second day within that normal 30-day pain range, or did we really flare something up on the first day of testing? So here's the physical demands of the job from two sources: the Occupational Requirement Survey under the U.S. Department of Labor and from the injured worker. And so the left-hand column, the very far left-hand is the physical demand requirements, and then the center column, ORS, here is the requirements per the U.S. Department of Labor under the survey, and then the right-hand column over here is the requirements from the construction workers. So based on data from the ORS, 95% of the jobs of construction superintendent fall within or classified within a sedentary, light, and medium physical demand level category. The injured worker classified physical demands of this job as primarily falling within a light and medium physical demand level category. So our functional test design and job match criteria are based on the data that's listed in table 2 here. So I also want to mention MET levels at this point, because part of my FCE testing is to assess the injured workers' MET tolerances, MET capacity, and with functional capacity or functional activities, and match that up to the MET demands of their work. So MET stands for metabolic equivalent per task, which is basically the amount of energy that's used by your body during physical activity. MET level of 1 represents what your energy expenditure would be just sitting quietly at rest. And MET level ranges have been assigned to each of the 5 U.S. Department of Labor physical demand level categories based on some original work that was done by Leonard Matheson and some other researchers back in 1993. The American College of Sports Medicine has also assigned MET levels to various occupations, activities of daily living, and other common life activities. This is published in the Compendium of Physical Activities that was recently updated earlier this year. So in my opinion, the use of MET levels and application of percent heart rate reserve in FCEs is a game changer for validating an individual's performance tolerance to safely participate in work activities, ADLs, and other life activities. And I'll discuss more about the application of percent heart rate reserve later in this presentation. So physical examination in this case, we've got a moderately obese senior citizen with high blood pressure taking a beta blocker. There's moderate impairment of right shoulder range of motion, mild to moderate weakness throughout all primary muscle groups around the right shoulder. With the active movement screen revealed he had mild to moderate range of motion impairments involving both hands, both wrists, his uninvolved left shoulder, his neck, and his low back. So he's ate up with a bunch of arthritis. He's got, spinal degenerative changes with stiffness and multi-joint arthritic changes and stiffness. Now, he was able to move into and out of a kneel posture during the active movement screen, but he required upper extremity support, but he was unable to move into and out of a crouch posture safely and independently. So that hence was removed from the functional testing battery. So now we'll talk about some other tools that I use as part of my FCE testing methods. I use the Omni 0-10 RPE, or rating of perceived exertion scale during relevant functional tests, to gauge an individual's perceptions about how difficult the activities were for them. For example, as we increase the intensity of a load the individual is lifting, we generally expect to see an increase in the individual's rating of perceived exertion and a corresponding increase in their heart rate. So in this case, the injured worker, we mentioned he had a history of hypertension, was taking a beta blocker, which is known to suppress heart rate increases in many people during physical exertion. So given that he had demonstrated no abnormal pain behaviors, no symptom exaggeration or self-limitation of performance up to this point, I really chose to rely more on his RPE ratings during functional testing as an indicator of his physical exertion tolerances to work over specified durations, instead of relying on the Bronner equation for heart rate. So we monitor heart rate continuously during the FCEs. We have a strap that can be strapped around the forearm or the upper arm, and that's linked to an iPad, so we can keep an eye on the heart rate continuously. With material handling, posture mobility, tolerance testing, and this is for three primary reasons. One is for safety. We don't want the patient's activity heart rate to reach or exceed 85% of their age predicted maximum heart rate. Number two is for part of the assessment of performance validity. We generally expect at least a 25% increase in heart rate above a pre-test resting level with material handling and some of the posture mobility tests as an indicator of good effort. And then third, it helps us to be a little more objective in assessing tolerance to perform work over specified duration and frequencies and intensities. So based on the patient's percent heart rate reserve calculations. So table 10 here illustrates the relationship between activity duration, percent heart rate reserve, and expected ratings of perceived exertion using the Omni RPE scale. So for example, when a patient's percent heart rate reserve is 50%, you would expect them to be able to tolerate the activity on an occasional basis, and they would typically are going to be reporting with that functional test battery an RPE of a 5 or 6 on the Omni scale. So heart rate reserve is dependent on an individual's age and their resting heart rate. So if you're young and you have a low resting heart rate, your heart rate reserve is large, and you have the cardiorespiratory potential to do work at higher intensities for longer durations, as compared to you get the 70-year-old in your office for an FCE, and they've got a resting heart rate of 100. Their tolerance, their tank is going to be much lower. So I also apply the concept of performance validity for assessing an individual's performance level with each of the functional tests and for the FCE as a whole. So performance validity is defined as the degree to which an individual's test performance is consistent with objective evidence of their health impairments based on biomechanical and cardiorespiratory signs of exertion, and then other operationally defined test endpoints. And there's two levels basically of performance validity. The performance was valid or invalid. And here's the 7 operationally defined functional test termination reasons with some examples of functional performance validity test termination criteria. So, for example, the test criteria met. So if the job demand required lifting 50 pounds occasionally, say below waist level, and you took them through a below waist level dynamic lift test, and they demonstrated the ability to do that, they would have met the test criteria. That's the reason we stopped the test at that point. Another common one is biomechanical signs of exertion. So as we're taking a patient through, say, a test, they are shoulder injury, and we're seeing as they do the lift overhead, significant muscle fatigue, muscle shakiness as we progress the load to the point where they're at a point where they're almost unable to safely control the load. The descent with the load as they are coming down is much faster, and the ascent of the load is much slower. So those are biomechanical signs of exertion and a reason to terminate the test. And the others are there as well, and just identifying which test termination criteria has been met and having an objective reason for that. So this slide represents kind of the different dynamic material handling lift tests and carrying and pushing and pulling that we do. So for the sake of time during this presentation, I'm just going to present a few, but not all, the functional testing data tables that I utilize for documenting an individual's performance during functional testing. So as a foundation for safe material handling abilities, I assess an individual's ability to safely perform 1 repetition baseline for a dynamic lift from below waist level, waist to shoulder, above shoulder, a 20-foot carry, and then a 20-foot dynamic push-pull. So this is a gradual progressive material handling protocol, typically starting with loads of 20 pounds, sometimes maybe 10 or 5 pounds, depending on the particular circumstances. And then loads are progressed in 5 to 10 pound increments until one of the test termination criteria that we looked at before has been met. So this is what we found in this case. The one repetition baseline dynamic waist to shoulder functional testing data table. We started at 20 pounds. I terminated the test at 30 pounds, and the test termination reason was biomechanical safe endpoint. It was a valid performance. And then the signs of physical exertion and reliability here on the bottom right section of what I observed and heart rate measurements, et cetera. You see that his RPE when we stopped the test was a 6, which if you recall there, we kind of expect that to kind of fall into an occasional range, but that heart rate increase of 26%. He had no change in baseline symptoms, so his pain level stayed a 2 with this test. So for that, evaluating occasional material handling tolerances, I utilized 80% of the individuals demonstrated 1 repetition baseline to assess tolerance to perform the activities at a pace that would be set at 12 reps per hour over a period of 30 minutes. So this equates to performing each of the activities only once every 5 minutes, and this would allow for a maximum of 6 reps in a 30-minute period. So with this occasional material handling circuit, which involves the below waist, waist to shoulder, above shoulder carry, and push-pull, they're going through this entire circuit in 5 minutes, and then they're going to repeat that circuit, same circuit, in 5 minutes. So, so with this, he reported no change in baseline symptoms again. He reported an RPE of 5, which corresponds to an occasional tolerance. So what he's telling us about his tolerance matches what we're seeing or what we tested for. His percent heart reserve, if you look at that, was 19%. Now, you know, that would suggest a tolerance to be able to do it on a constant basis, but we know it's not valid because he's taking beta blockers, and this is suppressing heart rate changes. And, you know, considering what we saw biomechanically with what he told us on the RPE, provides validation of his tolerance to safely perform these activities occasionally. The predicted MET levels here, anywhere from 3.25 to 5.14, are equivalent to a light and a medium physical demand level capacity. So I'll also administer a repetitive reaching tolerance test with him just to compare and look at impairment with the involved right upper extremity as compared to the left. So with this, he's repetitively reaching forward for 5 minutes with the left arm, and then he repetitively reaches forward with the right arm. He's placing pegs as he's doing this test. So we're doing like a peg count to see how many pegs is he able to place reaching forward in a 5-minute period with the left arm, and then with the right arm. And we do the same thing with overhead reaching 5 minutes. He's taking from a little bucket, a peg, putting it overhead, bring it back down, and we're doing that for 5 minutes and looking at how many he's able to successfully get. We saw, as expected, with that right shoulder, a greater impairment, 8% impairment compared to the uninvolved left shoulder. And then forward reaching was a smaller 3% impairment. So day 2, intake and physical exam, basically no significant changes. Pain levels 3/10. His right shoulder, physical exam revealed the same impairments. That pain level, again, you know, stayed within that 30-day pain range that he had reported on day 1. So with some mobility and posture tolerances, this is a 30-minute functional activity circuit to test his ability to tolerate standing, walking, gross manipulation, fine manipulation, overhead reaching, stooping, crouching, or stooping, kneeling, and climbing. The crouching was eliminated. If you remember, during the active movement screen, we found that he was not capable of safely moving into and out of the posture, so it was eliminated from the test battery. So the pace of this test is set for repeating each of the activities once per minute over a 30-minute period. So he's doing one stoop a minute, 1 crouch, or 1 kneel a minute, climbing a ladder rung, 2 rungs of a ladder once a minute, reaching overhead once a minute, and then some fine dexterity once per minute. So he completed 28 reps out of a max of 30 that he would have been able to do in that 30-minute period. He took no breaks during testing. And he also demonstrated a good heart rate response despite taking beta blockers, which confirms, in my opinion, valid test performance. If you look at his RPE, he's reporting a 7 there, which he's kind of pushing it there into a seldom category. And mainly, he was reporting the difficulty of a 7 with that, and drill down into it was the overhead reaching, the kneeling and the ladder climbing that was causing him the most difficulty. So he had a mild increase in his right shoulder pain and as well as bilateral knee pain at the end of testing with this. And then aerobic endurance, I administered the modified Chester step test here to look at aerobic endurance activity. So he completed this test up to stage 7 at a step height and step pace that correlates to a MET level of 4.48, which is, again, that's going to fall into a medium physical demand level category. He reported an RPE of 7, which was moderately hard, and overall, his performance was classified as valid with this because he met the test criteria. Part of the FCE that we use is also we administer a comprehensive pain assessment, and we do this to identify any abnormal pain behaviors that can contribute to negative functional test performance and/or delayed recovery. And based on the results of this assessment, he was classified into a normal pain profile. So basically, what he told us about his symptoms and activity limitations were generally consistent with objective evidence from the medical records that we reviewed, the objective findings from the physical examination, and then the functional testing results. So in this case, all of the patients, and this is part of the pain profile assessment, all the patients' body pain diagrams, which there were 4 of these body pain diagrams that were completed, one pre-test on day 1, another one post-test on day 1, another one on pre-test on day 2, and then at the end of day 2. So we can look and see if we're seeing changes in symptoms pre and post-test on each day. But all those correlated with objective medical evidence. All of the patient's functional pain ratings from anywhere from a 2/10 to 4/10 correlated with objective medical evidence. His responses on the musculoskeletal health questionnaire or the MSK-HQ, his symptoms and perceived activity limitations reported on that instrument correlated with objective medical evidence. And he did report using the PHQ-9 a mild level of self-reported depression, but it was not significant enough or it was not contributing to any maladaptive pain cognitions or delayed recovery. So this is the FCE Job Match Summary table. So you see up here his injured workers demonstrated physical demand level ability, fell in a range of a restricted sedentary, light, and medium. The physical demand requirements of the job, like as we mentioned before, the ORS had it as sedentary, light, medium. He stated it was mainly light and medium. So there was not a job demand match, mainly in the areas of the material handling. If you recall, he reported some lifting from ground level up to shoulder level of 50 pounds, 20 pounds above shoulder level, and then pushing a wheelbarrow that would be loaded with dirt or sand that would require a moderate amount of force occasionally. And this column here represents what his demonstrated residual functional capacity was based on all of the test results and review of the medical records and exam findings. So opinions and recommendations here is that, his job as a construction superintendent fell within that sedentary light medium physical demand level category, and that based on the results from the FCE, he was not capable of returning to work full duty as a construction superintendent. However, he was capable of returning to work in a modified duty job in that position, but is provided with accommodation for those functional limitations and restrictions that were noted in Table 1. Other opinions and recommendations, I include this: the residual functional capacity should be considered stable and valid for up to a year, and then an updated FCE would be medically necessary on or before that 1-year mark for a valid reassessment of his work restrictions if his work comp claim was still open and he had not successfully returned to work by that time. Also, always throw in that I would review any proposed job descriptions in the future to ensure that the patient safely manage a job that does not exceed his work restrictions. This is the exit survey I mentioned, and so after the patient's completed all of his testing, we asked them to stop at the front desk before leaving to complete a brief exit survey and to get them scheduled for a follow-up visit with their treating physician to review the results of the FCE. I administered the exit survey for quality assurance, but also for risk management reasons, basically addressing three key areas. Did we spend adequate time with you during the FCE to understand your symptoms and your limitations? Did we provide you with adequate safety monitoring during the FCE to minimize your risk of injury? And then overall, were you satisfied with the way that we conducted the FCE? So case reflection, the use of an active movement screen in FCE is an excellent tool to help examiners be more efficient in determining which test and measures to include in a patient's exam and functional testing. In this case, you saw that the treating orthopedic surgeon really overestimated the injured worker's safe functional ability by releasing him to return to work full duty when he wasn't there. And this is a quote that I came up with back in 2010 when we just opened the company. I added it to the website. So without a proper evaluation of an individual's function, work capacity, and disability are best an educated guess. I use that a lot of times in testimony, and it carries a little weight. So now it's time for discussion, and I'll list, I've got 2 pages of references here, so I'll just kind of start on this one and then scroll on to the next one as time allows. Any questions?
Chris?
Steve, I may have missed this. What methodology do you use for the FCE? Is it your own?
Yeah, it's a self-design. Yeah, I've been to Matheson and Eisenhagen and Ergoscience and many different, even workability. And there's good and bad, and I just have put together my own based on mainly what the evidence from the research shows, and then modeled after some of the ones that have been researched, like the Eisenhagen and some of the others.
Yeah, Steve, it's Rick. I went through it seemed like it was about a 5-hour deposition, and the attorney was so focused on asking about the workability model for doing an FCE, and I kept kind of going back to him and saying, well, our model is always evolving based on whatever is current best practice and best evidence, and it's not a one and done type of model, and I think the important thing is that we're selecting test elements that can be justified based on Dahlberg criteria such as reliability and validity. But there seems to be a lot of focus on trying to pick one brand and say it's the be all and the end all. And I just don't think that reflects maybe commitment by a particular brand to keep doing research on the items that they include in their protocol. And of course, each person has their own set of rules and needs. So we choose elements that are based on the person's health conditions, but also on the critical demands of the job.
Yeah, and we talk about the test termination criteria, and this is something that we really expanded on in the FCE monograph, because for years you've been doing FCEs for any period of time. For years, it's been the test termination criteria were biomechanical, physiological, or psychophysical. So physiological, being the cardio. So you had the biomechanical, cardiorespiratory, and the psychophysical, and that was it. Well, there's other reasons for terminating a test that don't fit into those 3 categories. And I think that was, what we were seeing, like with Matheson and some of the others that came out early on in the late 80s and 90s and stuff. And then So, there's the participation restriction or a behavioral cooperation concern where, this patient is stumbling and falling around. There's no physical basis for it, but you're concerned that they're going to either hurt themselves and claim an injury or something. And it's just what I call is that they're acting a fool when you're trying to get it through the FCE. So that point is like, okay, we're not going to do this. We're going to stop the test. And the documentation would be a behavioral cooperation concern and invalid. But then kind of documenting the specifics of what happened, what was going on there.
You have a good looking model. Do you oftentimes include pictures in your reports?
Yeah. The pictures kind of help explain 1,000 words anyway. One thing too, the heart rate reserve is just, to me, is really a game changer. I know, some people especially with the activity circuits like I do, where I'm doing a 30-minute activity circuit, it's just, really looking at their tolerance to the activities over a duration of period. And this, this is back to some old ergonomic research back from, that was published in the Kodak Ergonomics Manual. What is that, Rick, 1980 or something? And the research goes back to, a little further in the 70s. So we had a NASA scientist that worked with us. We took some of the original data that Kodak had published, and that's the 4 red dots on heart rate reserve. And he was able to create a linear regression equation so that we could then look at this time and duration, like over an 8-hour day, and then the heart rate reserve and the vertical graph here, and see what tolerance range do you see as far as your heart reserve, and how does that correspond to a duration. And so it's been great for me to, when I use this, and I can say, look, this validates that their tolerance for this is occasionally or frequently or whatever. The attorneys they have no further questions about that, about your methods, because the methods aren't this isn't based off Matheson or Eisenhagen or workability or any proprietary system. It's based off of evidence that's been published on heart rate responses and, some good science behind it.
Ben had a question? And Chris?
Yeah, thanks, Steve. Great presentation. You just touched on part of what I wanted to ask about, so forgive me if it's a little redundant, but you chose the circuit method over, testing maybe in a sequence of going from lift to push to pull and just working your way through the whole test. Was it mostly the heart rate reserve that led you to these circuits that you created? My question is, why did you choose the circuit, number one? And then number two, do you customize the circuit, or do you use a standard circuit with all your clients?
Yeah, so I'll answer that one first. So the circuit it's going to be, if it's a job specific FCE, then it's going to be custom. If it's any occupation FCE, then it's going to be generalized. But then if I see that the individual has limitations that will preclude their ability to return to work in that job full duty, I'm going to go ahead and expand testing and include all the other activities too, because then the vocational rehab counselor that's working for job placement say, well, his job didn't require this, but this other job that we found for him requires this, but you didn't test for that in your FCE. And it's like, well, I was doing it as a job specific, but it could have given her more information from a job placement so I try to go, generic and test multiple areas, even like keyboarding. There's some individuals that come in and their job doesn't require any keyboarding at all. But if the restrictions are to the point where Voc may be wanting to try to put them into an office position or some type of position where they're going to be doing keyboarding, I want to look at keyboarding proficiency. Are they finger pecking 8 words per minute with 6 errors? Or, how are they functioning? They're probably not going to be successful in that occupation. But on the heart rate reserve question, that was I was doing the circuits before that, and I was doing that to just look at, early on in my career, doing FCEs more than 20 years ago, I was doing more like the one repetition baselines here, and then taking a percentage of a one rep baseline to say, okay, based on that, they can do it occasionally, say 80% of that, they can do that occasionally, and 50% of that, then they can do it frequently, and the science behind that, there's not a whole lot behind it. You're taking U.S. Department of Labor categories and you're just, putting those numbers in there. So I said, I need to validate occasional, I need to validate frequent, and how do I do that? And that's when I started doing the circuits. And then the heart rate reserve kind of came along, and it's like, this is perfect. This helps to, because I could say that they, what their symptoms were and what their RPE report was. But, and as long as they, provided good effort, I could say, I think this is a valid indication of what they can do. But the heart reserve just provides that further objective scientific evidence that the heart rate responses also validate that they can do it. Now, where that really comes in handy is when you have an individual that wants to self-limit testing. And so they self-limit testing and the heart reserve is like at 10%. And, that falls into a constant range, and they don't want to lift more than 10 pounds. You have them do a lift, and it's like, that's all I can do. The test criteria was it was psychophysical and invalid at that point. And, I mean, there's other factors too. Say, based on the medical evidence, your physical exam, there wasn't any objective reason to stop it. Psychophysical, invalid. Heart reserve is 10%. Where does that fall onto that heart reserve curve? A constant basis. Say they could do this at least 10 pounds constantly. 10 pounds constantly falls within a medium physical examinable category. I find that, and say their pre-injury job was medium, I found no objective reason to limit them from being able to return to work full duty.
Okay, Chris, you have a last question? You're on mute. There you go.
Yep, there we go. So do you do any disability FCEs, or do you just do occupational health? So I will say that my favorite thing about doing FCEs, which I don't do anymore but did in the past, is the human approach, in that they are confident in what they can do when they leave, which is a huge gift because everyone is forcing them to do things, etc. But I was just wondering about your process and the psychology of doing a disability FCE versus doing occupational health, if it's different. Thank you.
The process really isn't any different outside of the disability FCEs we do, or, some of them they're individuals that are applying for Social Security disability, or individuals that are fighting like a long-term disability insurance carrier for benefits or continuation of benefits. And then some are referrals from the state vocational rehab offices where they're disabled individuals that want to go back to work and try to find and earn some type of employment that would not exceed that substantial gainful employment threshold, and make them lose their Social Security disability benefits. So the process with all of that is the FCE itself is going to be shorter, because most of the time, number one, the individuals are paying for it, or if it's a state referral, the state pays for it, and they just don't want to pay, for your time to do a 2-day FCE. So I've shortened the FCE down to up to a max of a 4-hour FCE for those type of cases. So they're scaled down. Instead of a 30-minute activity circuit, I'll do a 15-minute. And I mean, sometimes what you see, I guess possibly what you're getting at is this motivation for secondary gain and the percentage. Typically what I see in comp is about half of the population I see that have attorney representation, or personal injury cases. Those are 100% attorney representation, whether it's on the defense or plaintiff side. But in these other cases, most of the time they're not. They're struggling financially, trying to pay for this. So we've cut the cost in half, the time in half, and They, you typically don't have issues with self-limitation, and you typically don't have issues with abnormal pain behaviors or abnormal pain profiles.
Great job, Steve. And thank you all too for the questions. This will conclude our presentations for today, and we'll move into the general discussion. Thank you.